76-year-old lady who has had valve surgeries. She has a bioprosthetic aortic valve and also a bioprosthetic mitral valve. She's found to have severe pulmonary hypertension on the transthoracic echocardiogram. The question is, one, is it truly severe? And that's why we do the right heart catheterization to essentially confirm the findings on echocardiogram. And two, is this pulmonary hypertension fixed? Meaning, is there something we could give her to help bring it down? And three, it also helps us with the etiology. Is this related to her lungs? Is this related to her cardiac condition? So we see here our baseline, her PA pressure is 77 over 25. So immediately we know she has severe pulmonary hypertension. Anything above 60 essentially is classified as severe pulmonary hypertension. Her right ventricular pressure is obviously elevated 67 over 5. Her RV pressure, her RI pressure is about 20, so she does have some right-sided hypertension, right atrial hypertension as well. Interesting thing about the wedge pressure, her wedge pressure, we had a very large V wave, and usually when you see a large V wave, the first thing that you should think of is severe mitral regurgitation. But there are other things that can do that. Anything that causes an immediate increase in stretch in a non-compliant left atrium, a VSD, mitral stenosis, can also cause an elevated or a large V wave on the wedge string. So then what we do in this situation is we start our pulmonary vascular reactivity testing. So we give the patient 50 mics per kilo per minute of adenosine. We measure the baseline pulmonary artery pressures, and then we also do a baseline cardiac index, and we start the infusion. Basically you do that for 2 minutes, and then you re-measure pressures, and sometimes actually you measure cardiac output. And basically what you're looking for is a drop in the mean pressure, the mean pulmonary arterial pressure of drop of 10% and sometimes even 20%. What you see here, that you have several numbers. We start with 77, we go up to 80, and then we go up to 85, which is quite interesting in this patient. So, but our mean pressures essentially don't change. So in essence, this patient is not reactive to vasodilator, which means that if someone is reactive, those patients do favorably well on dihydropyridine calcium channel blockers such as Norvasc. In this case, she does not respond, so she's quoted as being, or she's categorized as a non-responder. In that situation, you try things like sildenafil, which is Viagra, or bosantan, which is endothelin receptor antagonist. But she doesn't change here. But interesting is her PA pressures go up, and one thing that we always have to be concerned about, and we're actually very well prepared in this situation, is that adenosine can cause bronchospasm. And if someone has reactive airway disease, especially in this patient who does have some underlying lung disease, she has diagnosis of asthma, you got to be ready. So before we even started the case, we made sure we had aminophylline, in the room, and sure enough, as we started to infuse, she started getting short of breath and started wheezing, and that's why her pulmonary artery pressures went up. In essence, they should go down at least 5 to 10% with adenosine, which is a normal response. In her case, actually went up because she was having bronchoreactivity from some of the adenosine. So we actually had to cut the procedure short. But nevertheless, we got to about 150 mics per kilo per minute of adenosine with no appreciable change in her pulmonary artery pressures. Her pulmonary vascular resistance, which was approximately 150 from what I recall, to really diagnose that, you basically divide that by 8 and you get what's called Wood units. And Wood units generally less than 4.
Key.